All right, well, I think we'll go ahead and get started. And as folks get connected, we'll welcome everybody. So thank you all for joining us today. I'm Susan Thornton, the CEO of the Cutaneous Lymphoma Foundation. I think some of you I know. I see some familiar names there. It's really great to welcome everybody to our live Q&A session. And before we go ahead and get started, I'll set some ground rules because we're tapping into the expertise of our clinicians, who I'll introduce here in a moment. But just to let everybody know, they're not able to answer specific questions related to your disease iteration, but we welcome everybody's questions, and we'll do our best to answer them in a broad way so that they have meaning and value for everyone. And oh, look at that. Judy Jones is with us. Haha. Our illustrious founder. So that's pretty amazing. Hi, Judy. And if you have questions, we ask that you put them in the Q&A box, and I will do my best to try to stay on top of that and to keep my technology moving. Excuse me if I miss something, and we'll do our best to get answers to everybody's questions, although we do tend to run out of time sometimes with the questions, but we'll do our best. So without further ado, we'll get started here. I'd like to introduce our expert clinicians who have given of their time and expertise today. We have Dr. Craig Okada, who's joining us from not Ohio. Good Lord. Oregon Health Sciences out in Oregon. He's a hematologist and works in the multidisciplinary practice out there on the West Coast. Welcome, Dr. Okada.
Thank you very much.
And we have Dr. Henry Wong, who joins us from the University of Arkansas, who is the head of the Department of Dermatology and has been engaged in the area of cutaneous lymphoma for a long time. Some of you may have participated or joined us for both Dr. Okada and Dr. Wong, who've been with us and working collaboratively with the foundation for many, many years. So thank you and welcome, Dr. Wong.
Thank you very much, Susan. It's a pleasure to be here and meet everyone virtually.
Yeah, great. And I see we've got a nice group of people here from patients. And so let's dive in again. I'll invite you to send your questions. Oh, here they come. See, I didn't even have to say it twice. People are putting their questions into the Q&A. So let's go ahead and get started here. So Chris was asking, why do you need to treat stage 1A classic mycosis fungoides if it will not progress? So I think that's a good question, right? I'll toss it up and see. Dr. Wong, you want to take a shot at that one?
Yes, I'll be happy to take that. Mycosis fungoides, cutaneous T cell lymphoma is a broad spectrum, and it has different stages. And a simple answer would be that these cancer has to start somewhere. And in many patients, it starts in a localized region, and over time, in a subset, it's unpredictable who will progress. We're still working on better biomarkers to identify who will, but having follow-up over time will give you your physician and yourself a chance to see how an individual's disease progressed. Now, there were studies that look at large population, and we do have some statistics. Over time, overall, mycosis fungoides is classified as more of an indolent lymphoma, but I think about 20% will progress to the next stage over 3 to 5 years. So there is a subset who progress over time, and so that's where it's important to follow up. I think the other comment I'll have is that in treating patients over many years, I think if you don't treat it, then you just let it go on its own, and it may, progress unrestrained. Now, in patients that we've treated, and most of the literature shows are from patients who have gotten treated, then it progresses slower. So that's one reason. And then, although we do say that we don't currently have a cure, I think every clinician will will report that they have experiences with patients whose disease undergo long-term remission after treatment. I'll leave that. Dr. Okada?
Yeah, so this is so stage 1 disease, meaning less than 10% of the body's surface area. As you probably already know, one handprint is considered about 1% body surface area. So as the question alludes to, patients with stage 1 disease do very well for very long periods of time. When they look at overall survival of stage 1 disease, it closely matches people without the disease. So it doesn't seem to, in most patients, I should say, it doesn't turn into a life-shortening type of malignancy. The main reasons to consider treatment is that the problem with this disease is that it does up the skin. One of the major complications we see with this disease is infections, because the skin gets beat up partly by scratching, itching, partly by sometimes when you do treat it, you get skin atrophy. So trying to keep the skin as healthy as possible by keeping the disease under control can help prevent some of those complications. Other reasons would be, as you might expect, cosmetic, rash certainly around the face and other areas can be distracting. The itch as well, so quality of life is another reason to continue to try to treat this. But as the question applies, do you have to treat this? Probably not, but the consequence, and you'll get an idea if this is progressing. If it just kind of waxes and wanes, whether you treat or not, then you have one of the more indolent. But if it continues to progress, then the treatment even has more importance, because it may slow down the progression to a more advanced disease. So I think, why do you treat stage 1 disease? Comfort, keeping your skin healthy, and some cosmetic reasons are the big reasons that I see for spending the time to put the topical steroids or going to the light box and things like that.
Great, thank you. Well, we have a couple of folks that are newly diagnosed. So couple questions around causation. Does stress have any impact on the disease at all? I know we've had some folks, there's, to my knowledge, nothing's really documented connecting stress with disease flares or intensity, but I don't know if either of you have some thoughts on that, having seen a lot of different patients. Dr. Wong?
Yes. Well, there, stress and the flaring disease, there, for certain variants of T cell lymphoma, the CD30 subset, these are lymphomatoid papulosis, not typically mycosis fungoides, but they can flare with stress. And I think there are, a subset of patients who have more CD30, which is an immune marker that we use to, characterize the pathology. That subset may have flaring with stress. Um, and we do know, stress causes a lot of skin worsening for eczema, psoriasis. I mean, we do see that often. And so I think it could potentially, make it more evident. Now, the question as to whether it alters the course of the disease, we don't really have any strong data there. I think, and for patients who have early disease, and that's where some patients' disease, the skin involvement can fluctuate, and that's, I think when questioning in some of those patients, I generally do ask, how are you under stress or any family events, work stress, to try to get a better sense of their disease activity and try to treat them appropriately that way.
Yeah, I find that I believe that many of our lymphomas, particularly the cutaneous T cell lymphomas, are influenced by our immune system. This is the best example of how much that can be is the LYP, which is kind of a pseudo, almost a lymphoma. We try not to call it lymphoma just because of the connotations, but people with that disease, it comes, spontaneously goes away. And one of the models for why that may occur is sometimes it gets the upper hand on the immune system and it can present as these little bumps on the skin. And then sometimes the immune system gets the upper hand and then they go back into and regress. They're probably still there, but they're not evident. Similar type of things can happen with other types of lymphoma, that when you're under stress, you produce these cortisone from the adrenal glands, and that suppresses the immune system. We know that infections overall and other things are suppressed, occur more frequently when people are stressed because of that cortisol. There is an extreme to that, though. I've had several patients with real bad MF who get very sick. One example would be they get bacteria in the blood and they get endocarditis and they're in the intensive care unit and their rash clears up. And that is because the cortisol level at higher doses or higher levels of cortisol rather actually affects the cutaneous T cell lymphoma itself. So there is some balance or variation in the disease intensity depending on stress levels and how the body deals with the stress. And the increases in the serum cortisol levels and suppression of the immune system. Whether or not stress leads to the development of cutaneous T cell lymphoma, that data is very, very hard to show. It's not a common disease. And so I don't know if we can say very much about the cause or, do people who are stressed get more cutaneous T cell lymphoma? It's hard to know that. And then as Dr. Wong implied, stress altered the clinical course overall. So how well people do in the long run. And that again is hard to know how much that plays a role. But we do see the intensity of the disease kind of wax and wane, somewhat related to stress levels there.
So take care of your stress levels as best as you can and find good ways to manage that, right? That's just all of our good overall health. Eat well, exercise, get enough sleep, and hopefully that helps your immune system be able to tackle this. That's great. Couple of questions around therapies. I'm going to try to put these together, particularly for early stage disease. Maybe you could speak to the different types of therapies, from skin-directed light therapy versus topical steroids versus, we've got, at least in the US, topical nitrogen mustard. How do you decide which therapies to use at what time for which patient, and how do you mix and match and kind of make that kind of determination? Any thoughts around how you work with that to get the best results.
Yeah, I defer to my derm colleagues to make those decisions.
Well, okay.
That's how I deal with it. No.
Well, yeah, early disease, I think, this disease is best treated by, skin-directed treatment. I mean, you don't want to start systemic treatments that may alter the immune system too early. With, for example, we don't. I think Dr. Okada doesn't use chemotherapy, but that has happened in the past, and we do see that from referring doctors occasionally. But yeah, so skin-directed treatment that for early stage is the best approach to start for the lesions that patients have for comfort, and also the goal is to try to clear the lesions clinically. I mean, symptoms as well as what we see. So the treatments that I think have been around include topical steroids. Nowadays we have more options, which is good. And I think in clinical practice, some of it is dependent on insurance, and so that pertains to really how we practice in the U.S. But as a first step, for lesions, topical steroids, high potency steroids to lesions can be effective. On their own, I think they don't induce a long-term remission, I would say, and often we use additional treatments. Occasionally some patients, the lesions, if it's very superficial, very just a faint erythema, it will go away. But a lot of patients with more prominent lesions, if they're scaly, if they're thicker, will require more than one treatment. And so topical steroids is the foundation for comfort. And then other topicals include topical nitrogen mustard. We have a company that makes it. However, it can be compounded, and that can be effective as well for those who can tolerate it. That treatment has the side effects of irritation in a subset of patients. 20% may have some irritation, and so we need to use different types of treatment. Another way to decide how we approach it topically is the extent of the skin involvement. Now, if someone has 5 to 10% of their skin with lesions scattered over their body, then phototherapy is a very effective way to treat it. And by phototherapy, what we have now is narrowband UVB. We have different types of ultraviolet light treatments for mycosis fungoides. Now, you could also, besides narrowband UVB, which I think is available almost all over the world. I mean, in Europe and Australia, that they should have it. And then we certainly have manufacturers in the U.S. And in North America where patients can get home UV therapy if the dermatologists don't have it, or if it's too far, or if the site is just too far away. Now, narrowband is the most common type of phototherapy that we have. The other type of phototherapy is called PUVA, and that's harder and harder to find. But I would say, having treated patients over many years, it is still one of the treatments that can be highly effective for patients who don't respond to the standard treatment, and it's a good option for a certain subset of patients. And that treatment is PUVA, means psoralen plus UVA. So in that treatment, patient would take psoralen pills that would sensitize the skin about, after taking the pill, about an hour, they would go into a light box that is UVA, and they would have a UVA ultraviolet light treatment in combination. Now, in that treatment, after the rest of the day, the skin is sensitive to additional UV light. So patients need to be aware of that, and they need to shield their eyes and then make sure they're not out in the sun. So those are the phototherapy. Other treatments that I think that have been shown to be effective is agents that stimulate the immune system. One of the consequences of the mycosis fungoides developing in the skin is it does weaken the immune system, and there's local loss. And one way to get the body to treat the lymphoma is to use agents called imicramide. It's it stimulates the molecules and it stimulates the immune system through toll-like receptors, activates the immune system, and that can get the body's immune system to treat and attack the mycosis fungoides cells. So that's available as well. Another group of agents include the topical retinoid. In the US, it's bexarotene is available in a gel, but there are other retinoids, and we've used even the ones that are available for acne or psoriasis that can be effective. Bexarotene itself is a little bit expensive, so that's generally the problem with that, and it's hard to know whether it's available across the world. But retinoids that are used for psoriasis or acne can be helpful in combination with steroids. So those are some of the topicals that can be used, and a lot of the way that we try to adjust the how a patient tolerates it is to see, is it comfortable? Can they use it? Is it not so irritating? So we find a combination that is tolerable and easy to use, and we can get from the pharmacy. So there are a lot of options, and exactly how to decide, really it's patient dependent, and what and how and what's available, what they've responded to, what they haven't. So I think it's trial and error for each patient.
Great, thank you. Thank you. And maybe just as an add-on here, some questions around how long does it take phototherapy and some of the other treatments to work? I think that's also one of the challenges, right? It's not an immediate, you get a light therapy and your disease disappears, or you apply something, or even if you're requiring systemic therapy, it's not like it's an immediate response to the treatment. So how, from a patient perspective, what kind of timing should people have in their minds, and how do you understand with the therapy that you're on, what's that timeline, right, when you should hope to see a response?
Right.
That's a hard question, really, but
I think that's very reasonable. So this disease develops sort of insidiously sometimes, very often. So it doesn't, explode on the skin. So our goal, when I tell patients, we don't try to use medications that, get rid of it in a week, because the side effects of those treatments are probably, are too great. So that's really unrealistic. Generally, I think it's important to be disciplined. I mean, lesions slowly fade and regress over time. I think, for each treatment that we start, I think give it for topicals, give it up to 2 months before we say a treatment fails. And then for for phototherapy, phototherapy is a treatment that is very safe, generally well tolerated. And for that, patients usually get treated 3 times a week initially. And as the lesions clear, then we taper the treatments. Generally, patients are on it let's say 3 times a week for about 2 months. And as they improve, then they're tapered to twice a week, and for another 2 months. And then if the lesions clear, then they're on the treatment once a week for 2 months. So patients are on phototherapy for a long time. So it's a treatment that they have to be dedicated to. And for patients who have to travel to a site, it does require a significant commitment for that. But yes, a couple of months at a time, and we, as long as patients are responding, I think we keep treating the patients until the lesions clear.
Great. Dr. Okada, any thoughts on perhaps some of the systemic agents that we have as far as time to response and what folks might expect?
Yeah, so just so for early stage disease, yes, skin-based therapy is the mainstay. We will sometimes use some systemic agents to help the skin-based therapy. So you may hear of bexarotene, which is a retinoid, derivative of vitamin A, used at low doses, 2 capsules once a day. And that has been shown to help the light therapy work better, meaning faster responses, deeper responses, longer duration responses. At that particular dose, there are not a lot of side effects. It's usually pretty well tolerated. There, and the other thing that, at least in the States, is oftentimes used, especially on the East Coast, is the cytokines. Gamma interferon is one of those. It's a bit expensive and you have to self-inject, but that also seems to help the skin-based therapy, mostly the light therapy. To get to the timing of how long it takes to get responses and stuff like that, it's really difficult to generalize because thicker lesions respond slower. If your lesion happens to go deep into the skin on the hair follicles, so follicular tropic mycosis fungoides, we actually struggle with the skin-based therapies, even though they may have limited stage. Just that the light, and many times even with PUVA, the deeper light therapy doesn't get down that far. And that's an example where we would certainly try to use systemic therapy as an adjuvant, or even with early stage disease, go into consider systemic therapy more quickly. The difficulty we have with the time, so the corollary to that is how long do you do a treatment before you say you need to do something else? And it varies so much. That's why it is important that if not being cared for by somebody who's familiar with this disease, at least have some kind of shared management with the experts who do have this field, because it is unfortunately not a textbook algorithmic driven management for managing patients who have this. There is a lot of nuance. There is, you've heard a bunch of this, that it just, it's hard for somebody who doesn't treat this disease to say, that's enough time, it's not working, we need to move to something else, or no, that's not enough time, let's, continue to treat. So I know it's a vague answer to the question, how long do you wait? But it just varies so much, and there's some nuances to it as well, to know when to move to another therapy. And as Dr. Wong suggested, is that unfortunately it also is a bit of a trial and error type of thing. Even when you look at a patient, you look at the rash, you say, oh, that should work. You find that it's a little heterogeneous. There's not always the good, easy predictive to say that will always work, at least with certainly with the skin-based therapy and in many of the systemic-based therapies. Get to your last question, when do we do systemic therapy? So certainly more advanced stage disease, but also if you start going through some of the skin-based therapy and you're not getting responses, or the responses are transient, then we start looking at the systemic therapies. We do have a whole bunch of them. So it also implies that it's same kind of problem. You got to pick one that you think is going to work and see if it does work, and if it does, continue, pushing that therapy. But it is a little nuanced to know when to move to systemic therapy as the main way to treat it. But as I mentioned, we step in with adjuvant systemic therapy relatively early if their disease is not responding quickly.
Right, great, thank you. And as I think the terminology is, if you've seen one patient, you've seen one patient, and it's a very individualized journey, right, for both the patient and the physicians. And I think it's also really great for us as patients to keep track of our own therapies and how our disease is presenting, because that then helps to inform, how things are working, what's working, timing, and that kind of stuff. So I just encourage everybody to keep track themselves, because that can also be very helpful. Interesting question here. And I know we're got just about 10 minutes to go here. George asks, if there's no evidence of the mycosis fungoides on the skin, but there's still itching, does that mean that the disease is active? Or is there a correlation between, even if you can't see the disease, but there's still residual itching? Any thoughts on that?
The itch has always perplexed me, because exactly that. You sometimes have itch with no rash. Sometimes you have rash with no itch. And obviously, the more common is to have itch and rash. We usually correlate the itch to disease and how active the disease is, but that correlation is definitely not 100%. So short answer to the question, if you don't have a rash but you have itch, doesn't necessarily mean you have active disease, meaning if you did a punch biopsy and you look for that cutaneous T cell lymphoma in the skin, you may not find it. The other problem is the biology of itch is poorly understood. It does travel along some of the same receptors as the pain receptors, and so that's why some of these medications we use for the itch to calm the pain nerves, gabapentin, pregabalin, and some of the other medicines we use that work centrally for the nerves, so those would be like the tricyclic antidepressants and things like that. It can help with the itch, but it is a problem. And most patients I know who have the itch and the rash, they can live with the rash. It is the itch that really compromises quality of life, doing what you want to do, sleeping at night, because that seems to amplify at night when you're relaxed and you're focusing on trying to go to sleep, and then that itch just keeps you awake. So we do want to treat the disease, but if the itch persists and you don't have a rash, the focus should be more directed toward trying to treat the itch part using some of these other methods. And we have a number of different options to try on those, including the neuroleptics, the gabapentin, pregabalin.
Great.
Yeah,
Great.
I think in a subset of these patients that even though you don't see the lesions anymore, I think it can be subclinical, and even a biopsy may not review it, uncover the abnormal cells. But I would say sometimes it just suggests that we haven't completely cured the disease, put it into complete remission. So I agree. It's still important to treat the itch because that's a very uncomfortable. It's very disruptive, and and one treatment that we do have, ultraviolet light is very effective in addition to some of the other systemic agents, the gabapentin that treats the itch. Phototherapy is very effective, and so that's another modality that can be used, and it will also at the same time keep whatever what we can't see. It will be treating the subclinical CTCL at the same time, so that would that's an option. So itch is important.
Great. Thank you for that. Okay, a couple more questions as we're ramping down here. Can you speak to your experience with the use and efficacy of brentuximab in mycosis fungoides with CD30 expression? So
yeah. I can try to hack. So this is a drug that we commonly use. So what brentuximab is something called a monoclonal antibody that's conjugated to a chemotherapy drug. That antibody binds to the CD30, and so the thinking is you can more specifically target the chemotherapy to the cells you want it to target to. What's been a little bit surprising is that the amount of CD30 that's expressed on the tumor cells can be very minimal. Young Kim at Stanford headed a study, and they would show that brentuximab has some clinical activity in people who would normally be called CD30 negative. When they look with more sensitive ways, you can actually see it, but just not much there. In the clinical trials, they did a meta-analysis of all the ones available. The overall response, and my personal experience too, about 70% of patients who have a CD30 positive cutaneous T cell lymphoma have a response to that. The anaplastic large type of cutaneous T cell lymphoma, it's closer to 90, but it is a very high response rate. So it's a good drug. The main side effects we worry about is the neurotoxicity. This particular vedotin chemotherapy can cause neuropathy, and it's oftentimes the limiting thing that we find that prevents us from using the doses we want or the duration of treatment we want. So high response rate, the duration of response is very, very good. We are able to retreat if it goes into remission and then comes back. Has not been well studied as a quote maintenance for cutaneous T cell lymphoma. In a different disease that also expresses CD30, Hodgkin's lymphoma has been used in that setting, but we don't know if that's a good idea for the cutaneous, meaning doing an infusion of brentuximab every 3 months or something like that to quote, keep a lid on it. That just hasn't been done. Anecdotally, I know some people are doing that, extrapolating from other studies. So a good drug if your disease happens to express CD30.
great, great.
Yeah,
And here, oh, go ahead, Dr. Wong.
Yeah, I think for MF I think it's for MF who patients who have progressed and have failed other systemic treatments. I think it is a good treatment, good modality, good option to try. I think in the patient population that we've treated, I mean, it tends to reduce the burden of disease, but doesn't always clear patients. I think another comment that I would just like to add, I mean, I think Dr. Okada said earlier about combining retinoids with phototherapy. I think combining multiple treatments to identify a synergism is one way to enhance efficacy. So the patient's not responding to one treatment adequately. I think in my practice, I've stacked additional treatments. For example, patients who are slowly responding to phototherapy, like Dr. Okada said, adding a retinoid, bexarotene, acitretin can really accelerate or help clear the lesions more effectively and really get to a clinical remission. And this probably also applies to systemic treatments. I think bexarotene in combination with the newer treatments are effective and can increase the sort of the data from clinical trials. So you get clinical trials usually shows results from monotherapy, but I think in real life practice, I think we can get better responses with combination treatment. So it's important to be evaluated by clinicians, teams who have experience with the different options for treating CTCL.
Great. Oh my gosh, I can't believe we're at the bottom of the hour already. And I know we didn't get to answer everybody's questions. We'll try, and everything in the Q&A and in the chat, we'll keep, and we'll try to get some answers offline and provide them back to everybody so that we can do our best to get the questions answered. There's always so many and never enough time. But thank you, everybody. And thank you, Dr. Wong and Dr. Okada, for taking time out of your Saturday to join us and to share your wisdom and your experience. I think it's always so helpful for us as patients to build our own knowledge so that we can take as best care of ourselves in collaboration with our clinicians to manage our diseases. So I think we're taking a little break at this point, and then we'll be back with our wonderful patient story. I encourage everybody to come back and join us. And then we've got our networking group. So I look forward to seeing everybody in a little bit of time. And Dr. Wong and Dr. Okada, thank you so much again. We really appreciate your time, talent, and expertise. So we'll see everybody in a little while back on the other Zoom. Take good care, everybody. Have a great afternoon.
Thank you, Susan.